But tell me about the prevalence and the burden of this disease. How bad is it? Who's got it?
So thalassemia is prevalent worldwide. It's estimated that about 80 to 90 million people are carriers for one of these thalassemia genes. That's about 1.5% of the population of the world.
1.5%. This is not a small problem. This is a biggie.
These are carriers, though.
That's okay.
So
that gene is out there.
It's out there, and it's estimated that in Italy, for instance, there are about 6,000 affected individuals who have thalassemia, the disease. In the U.S., it's about 2,000 or so. That's an estimate.
Right.
But there's probably the major burden of it is in Asia,
Really?
which you find in the Southeast Asian countries, the Indian subcontinent, and then all the way extending through China as well.
That's interesting, because when I was in medical school, when pterodactyls flew through the sky, it was always presented as a Mediterranean problem. Yeah. Italians had beta thalassemia more than
Greece,
others.
Italy, Greece. But you know why? That's distribution? Malaria.
Is that why?
Because malaria was a selective natural factor, and the carrier of thalassemia gene were surviving to malaria. So if you overlap the map of malaria in the world and the map of thalassemia distribution, they are exactly overlapping.
They match. It's the same with sickle then, right?
Exactly.
These are survival adaptations, which
and
unfortunately have some downsides.
That's also true for other red cell defects, because the red cells survive better to malaria infection.
So how does this disease present? How do you work it up? How do you recognize it in your office or in your clinic?
Well, I think the presentation probably depends a lot on what part of the world that you're in. I mean, you know, classically, these children present at several months of age. I mean, you know, initially when they're born, they have fetal hemoglobin, and then they
That's protective.
As protective, because fetal hemoglobin is alpha chains and gamma chains, and then you switch to beta chains, and so in beta thalassemia, somewhere around 2 to 3 months of age, they begin to become anemic.
It's not an accident that it's beta thalassemia.
Beta thalassemia,
Beta chain is where the problem is.
Right. I mean, there is a gamma thalassemia, but it's pretty rare. So, so they present with anemia. Now, there's over 300 mutations in the beta chain that can cause this, and so there's a very broad range of severity of how these kids present. But generally, they present with anemia in early infancy. And
what about growth failure?
Well, this depends a lot upon what kind and when they become anemic and how anemic they are. And so normally when they present to the physician, it's because of anemia. They could have big spleens because of the body's trying to make more red cells and make more hemoglobin, but it can't. So it reverts to making hemoglobin in the spleen and other places outside of the bone marrow. But anemia is primarily the presentation. Now, whether they have growth failure or not depends again on the severity. If the patient's hemoglobin level isn't so bad, the growth may not be so bad. I mean, normal hemoglobin is around 12, let's say. So if the baby's hemoglobin is at 9 or 10, they won't be so affected. If they are thalassemia major and their hemoglobin is 5, then they'll begin to have growth failure right away.
What about effects on the heart? What about thrombotic problems with this?
Well, again, when you're talking about presentation, so these things that occur when the patients are much older, and it's a lot more, you know, these classical things that people think of it. It depends, and again, maybe that's a problem with the 4 of us here, is we know what too many of these depending kinds of things are. Certainly, when the patients are older, they have problems with thrombosis and they have a lot of other difficulties. But usually, we intervene with treatment. Now, a lot of places in the world, especially in the Western world, the clinical presentation is at birth, because people have newborn screening programs. And so in the United States, for example, or in California, all the babies are screened. And so we get a letter from the state of California within, you know, really days or weeks of birth, notifying the physician, notifying the parent, notifying the local thalassemia center that the child has been born, and they're recommended that these kids then go in to be seen. So they're diagnosed really even before they develop symptoms.
But I take from what you're saying that when you're talking about cardiac abnormalities, you're talking about thrombosis, these are later. And early on, what you're really looking at is the anemia once
Well,
the hemoglobin F goes away.
So before people learn to start transfusing these patients, you know, the children usually didn't survive the severe ones. Again, this is very important. Remember, there's 300 different genes, just for purpose of a discussion, which means there's 300 from the mother, 300 from the father, so there's a lot
There's
of
a lot of
possible
polynomials
a
here.
lot of possible combination here. But in the kids that had hemoglobins in the 4 or 5 range, I mean, they usually didn't make it to age 5 or 6 years of age. Then people figured out that if you routinely transfused the patients, they would survive much longer. But then, because transfusion gives you iron, they developed iron overload, and the median survival in the 60s and 70s was around 15 years of age approximately, and there they would die from heart failure, or mainly from heart failure
Liver's
secondary
involved too,
to
so-
iron overload.
Right.
Well, it's primarily the cardiac. The liver certainly is involved, but the big problem was iron cardiomyopathy, and then of course endocrine failure.